So Dr. Vibhuti will be talking on wiping out the wipeout phenomenon, tips for prevention. Dr. Vibhuti, please.
Hello. Thank you, sir, for giving me this opportunity. I'll be talking on, in a brief, how to wipe out the wipeout phenomena and what are the tips. Having said that, most of the surgeons don't prefer to operate upon a trabeculectomy even in cases which are very advanced, just because of the fear of losing the sight, whatever reason the patient has. But in my take is, you have to take chance if you want your patient to survive for a little longer. That's the only situation, and you have to do. So this is also known as snuff syndrome, rare yet possible complications. It is very rare. I mean, from 1% to 13% is the chances of occurrence, and usually seen in patients who are very advanced at the stage 4 or stage 5 glaucoma. So defined as a permanently early post-operative irreversible reduction of the visual acuity to less than 6 by 20 by 200 or to the counting finger or less if pre-operative vision was below 20 by 200. Or if you see that wipeout phenomena, if there is a loss of central visual field with a retinal sensitivity measuring 0 decibel in 4 points abutting fixation on both the central 10-2 and macroreal threshold program, that is wipeout phenomena. So you can see these are the cases like very advanced kind of the glaucomatous damage, or the patient where there is some amount of changes in the 10-2 macular program. These are the patients who are very prone to developing this wipeout phenomena. So incidence is, as I said, less than 1% to 13%. The chances of occurrence is there. There are various prospective as well as retrospective studies, and which presents various incidents in these cases. However, having said that, the chances is always there. So what are the risk factors? The risk factors are the old age with a high preoperative IOP, preoperative split fixation, choroidal effusion, retrobulbar and peribulbar anesthesia, undiagnosed high IOP. So one of the most important thing is the patient with a very high IOP whom you are operating and sudden decompression is there, or when you operate upon and the patient is left with a shallow chamber for a little longer period, and that can lead to some amount of the choroidal effusion or a very turbulent post-operative phase. These all three conditions can develop into the wipeout phenomena. Having said that, this is very rare phenomena. There are other chances also with local anesthesia. Direct trauma can occur to the pressure to the nerve, since we know that very few fibers are left. Even the macular fiber is a split sometimes, so there are very few fibers, and if you leave the patient even with a slight increase in the IOP a little longer for the little longer time, that can damage localized pressure to the optic nerve or the volume of anesthesia if you trap them within the facial layers, leading to the compartmental syndromes. Adrenaline in local anesthesia again can be a vasoconstrictor and can create some kind of problem. Even hyaluronidase is associated with orbitopathy and optic neuropathy, and they can result into the damage. Then pressure spikes in the intraoperative as well as the post-operative phase. If you have sutured the scleral flap very tightly or fistula blocked with iris tissue, or you leave the viscoelastic into the anterior chamber in these patients, and in the post-operative phase, if the IOP is very high, that this can lead to a split kind of the fixation. So etiopathogenesis are associated with the occurrence of sudden intraoperative ocular hypotony during the glaucoma surgery, or optic nerve hemorrhage, or microembolic episodes. So post-operative hypotony with choroidal effusion can be an independent risk factor in one of the studies. So preventing hypotony is very important. Timing of release of the releasable suture is also very important in these cases, so as to titrate the IOP in the post-operative cases. So advanced visual field defect affect the central field with a split fixation. So what are the things which we should do? Pre-operative evaluation, a good pre-operative evaluation and the risk analysis has to be performed to identify if there is any risk factor associated with this patient that can result into some kind of the wipeout phenomena. Patient presentation and unexplained decreased visual acuity more than 2 lines on a Snellen's chart, or duration first 2 weeks post-operatively and persisted for 3 months. The post-operative evaluation is very important in trabeculectomy patient, first post-operative day, day 7. If the patient has some kind of high IOP or lower side of IOP, then naturally you have to keep the patient on a regular follow-up, visual acuity and IOP in all fields, visual field management, visual field assessment at the 3 months, and the use of the 4 central visual field in addition to the mean deviation is very important. So to do things are, to note any early undiagnosed post-operative IOP spike. IOP should be monitored few hours even after the surgery. And in these cases, who are at very prone, since the patient has already that advanced kind of the glaucoma, so it has to be monitored. Controlled IOP pre-operatively, use of subtenonal anesthesia is good. Avoid use of adrenaline in such patients. You can always use brimonidine in the early before the surgery so as to prevent the bleeding. Use of antimetabolite to reduce the subconjunctival scarring and the failures can be reduced. Use of ACM is also one way to decrease the chances of occurrence of the sallow AC during the intraoperative phase. Or what is important if you do a trabeculectomy and you come out without ever changing the depth of the anterior chamber, so that is the best situation. And always take out the viscoelastic from the anterior chamber at the end of the surgery, so that the post-operative complication doesn't occur. So this is all about the wipeout phenomena which I want to say. There are a few more slides which I would like to skip. Thank you very much, sir.
Thanks, BIBHUTI, for these nice tips. Thank you very much.